Hello, everyone. Welcome to today's webinar brought to you by the Systems Planning Collective. This webinar is all about systems integration and is called Systems Integration in Practice, Practical Learnings from Communities Working Across Systems to Tackle Complex Social Issues. My name is Lindsay McRae. I'm a communications officer at the Canadian Observatory for Homelessness, and I'll be your contact throughout the webinar if you experience any tech issues. To reach me, just send me a message through the questions box, and I'll get back to you as soon as possible. Before we get started, there are just a few things to note. This is a listen-in webinar, meaning if you have any questions for the presenters, type them into the question box that you'll find in the control panel, and we'll be sure to get to them during the Q&A session at the end of the webinar. We'll also be sending a recording of this webinar to everybody here with us today, so not to worry if you miss anything or have to leave us early. The webinar recording will also be posted on our Vimeo page, so there's lots of opportunities to catch on anything you've missed. And on that note, I'd like to introduce you to our incredible panelists and brains behind this webinar. Alina Turner, Principal of Turner Strategies and co-founder of helpseeker.org. She's also a fellow at the School of Public Policy, the University of Calgary. We also have with us Dina K. Beno, Housing and Homelessness Coordinator with the City of Abbotsford, and Jamie Rogers, Manager of the Homeless and Housing Development Department with the Medicine Hat Community Housing Society. And with that, I'm going to pass it on to our first speaker, Alina.
Hello, everyone from all over this beautiful country. Wanted to thank you all again for joining us in this monthly webinar series. And today we're tackling this complex issue of systems integration. So if you are somebody that's working in public systems or health, justice, as well as child intervention, education, as well as, of course, the homeless serving system. This webinar is really targeted to inspire you with some of the most recent learnings around systems integration from the academic theory side, research side, and then to give you some real life examples of what communities are doing on the ground. So we have Dina from Abbotsford, BC, and Jamie from Medicine Hat. So two communities that are doing some excellent work to give you some inspiration in your local efforts to prevent and end homelessness. So my presentation is going to focus on the big picture so that we can have some context around what systems integration is really all about and what it means when we're applying that lens to our work in homelessness. So while we're honing in on homelessness, that this is an opportunity to think a little bit bigger beyond the homeless serving system. So I'm going to give you the systems integration overview, and then keep clicking to bring everything up. We'll understand this imperative, so to speak, around integration and why it's so important, then go on to the two examples in more detail and have some time around discussion and what's next. Right, next slide, please. Okay. So the big thing to remember here is that while we're speaking about this idea of a homeless serving system, we all know that it's not really a system in and of itself. It's not really a silo. It works in a broader ecosystem of our social safety net, and that includes things like justice and income assistance and housing and health, etc., children's services. And really, it's really quite tough to say what one system is and where it begins and ends. And what we'd rather think about is this web and interconnections between all of them, and therefore our work needs to be done in a holistic and integrated lens as well. And folks on the front line know this very, very well. Sometimes it gets lost in the policy and program streams and eligibility criteria that, in fact, people are people and their issues are interrelated. So it's important to apply that through and through at the systems level and in the frontline work as well. Okay, next slide. So why we need to think about an integrated approach is, of course, because we know from a bigger perspective that all of these systems need to work together to actually resolve complex social issues. And while we think about homelessness, oftentimes some of you are in the midst of developing things like safety and well-being strategies, right? So those are even bigger imperatives around integration. So anybody that's working in Ontario, you're probably in the midst of developing your well-being and safety strategies as well. And we would argue that there's no reason why your work around homelessness couldn't be a critical part of that work, and vice versa. So things like well-being are concepts that push us towards an integrated approach to these complex issues that are themselves really only achievable in terms of impact using an integrated approach. So the community-based mechanisms around governance, strategy, funding coordination, and service integration should also apply this lens as well to ensure that our resources are aligned across all of these in practice. So that's at least the dream, the theory, that if all of these pieces were working together well, theoretically we wouldn't have things like homelessness, because all of these, the safety net was actually plugging up all the holes that wouldn't cause somebody to become homeless in the first place. Okay, next slide, please. So a couple of examples too from other communities that are thinking like this, and here's one from Edmonton and how they're designing their homeless serving system and recognizing how it kind of starts to integrate into other components of the social safety net. So you can see the typical on the left-hand side, or my left-hand side at least, the homeless serving system program types or service buckets that you're probably familiar with, founded around the idea of coordinated access, and then the various interventions that stream according to client need from there. But then you can also see that there's a need to not necessarily duplicate, but to integrate with things like community-based housing. So the private market social housing, rent subsidies through Capital Region, which is their social housing management body, but also things like United Way and Poverty Edmonton, so poverty reduction initiatives that are themselves are working in this space, especially when we think about prevention. And then of course the public system services and supports, so everything from income assistance to immigration settlement, domestic violence supports, etc. And some of those are delivered by nonprofits, some of them are delivered by private sector counselors, etc. And some of them are internalized or delivered internally by governments themselves. So you need to understand all of this whole ecosystem to see where the homeless serving system fits and plugs into these, and vice versa. They should be looking at their own services and see where they begin and end, and how they complement other parts of the ecosystem. Next slide, please. So a couple of things that, again, we're learning more and more from the research side too, and this will be intuitive to you if you're working on the front lines again, and we hear this all the time in our lived experience consultations, that individuals are more than the sum of their issues, right? And so the idea that we can divide the individual by their presenting problem and then create a system to address that one problem has created this really complex web that's become more and more difficult to navigate at the individual level. And then at the front line, similarly, trying to patch together the system to meet the needs of the individual has become increasingly complex, because the service system is so intricate, and everybody has their own eligibility criteria, funding streams, etc. Sometimes in the exact same organization, you have all these different funding streams that you need to manage, and everybody needs to produce outcomes that are somewhat different depending on who's signing the checks. So what we're proposing and moving this work forward, especially when we think about a prevention, well-being, and a systems integration lens, is that we start looking at this from a holistic perspective, and we look at that individual and the family in the context of relationships, community, society, and then start to put back together the system from a human-centered lens and build it from the human-centered lens out, as opposed to the system lens in. And so when we look at and we use the concept of well-being, but you might use other concepts. It's one that's starting to get some traction in terms of usage in different policy circles and research bodies. But it's just the idea that you've got the right human rights and basic human needs as well. So there's that rights-based approach embedded here, and certain things are really essential to that. So, you know, the right to housing, right to safety, inclusion and belonging, civic participation, income, adequate income, recreation and education opportunities, adequate employment. So all of those things are essential to somebody's well-being, so for somebody to thrive. So we necessarily should be looking at the system through that holistic lens, as opposed to saying, well, I'm only doing the housing, and once the housing comes in, then the rest, that's somebody else's problem. Rather, we should be saying, us as a system have to deliver in our work around this, the needs of somebody and their rights in terms of basic needs and beyond basic needs as well. So then how do we build those systems across these various programs that have been developed with really, not myopic, but really targeted foci over the last several decades, really. And so what you're going to hear from the community lens is that that's exactly what folks are doing, is they're taking a strength-based, rights-based, and holistic approach that is now kind of prompting this integration in systems to kind of bring them back together so that they focus on the person instead of the funding stream or the program itself. All right, next slide. So a couple of integration, I wouldn't say best practices, but learnings from other communities that have attempted to operationalize this work. So again, they usually have some kind of a common framework, and I talked about well-being, and it could be other imperatives, but there's usually some attempt at aligning policies and protocols, at sharing information across, let's say, health, justice, etc. Service delivery is done in a coordinated fashion, so that there's not, you know, 3 different case managers for the same person working on different items. There's actually an intentional focus of staff around promoting systems and service integration. So it's everybody's job from the top of the organization to the frontline level. There's some kind of a leadership or governance mechanism to ensure integration is being not necessarily mandated, but promoted from the bottom up, top down, and at the management levels throughout. So the leaders of systems, the CEO of health regions, or the key funders in homeless serving system, whoever those decision makers are at a local, regional level, are on the same page that this is a priority. There's usually a strong homeless system planning and coordination organization, and if you're a community entity or if you're working in that space, you know what I'm talking about. There's some backbone support that's actually trying to make sure this is happening across services. And sometimes we also see this manifest in co-location. So services that were traditionally not living together are now kind of moving in, and you actually hear from Dina and probably Jamie as well about what that looks like from a physical perspective, and some way of sharing information as appropriate and with client consent and all those good things. But there is sharing of information across systems to actually complete the picture and understand what's happening, because we're all recognizing we're on the same team, so to speak. So next one, please. And here's a couple of tips from a recent paper that I wrote with Diana Cressy from the Calgary Homeless Foundation, and our learnings from some of the experiments happening in Calgary. And this was published through the School of Public Policy at U of C, so please feel free to download it. But the basic message out of that entire big paper is that we need to have a line of sight at the user level, at the client level, in all the integration work that we're doing. So while I talked about things like policy and information sharing and all those strategies, sometimes there's a danger in us becoming so enamored with integration that we start creating all of these great integration mechanisms that lose sight of what they're actually trying to do, which is make life better for the person that they're trying to assist. And so what we saw in Calgary, and I would say I see this a lot in different communities, is that everybody gets really into integration, and we start pilots, we start task forces, and sometimes those task forces take up a lot of time, a lot of procedures, and more administration, and in fact make the system even more complex to navigate. So I would encourage you to think about that too, is if you don't have a clear line of sight to outcomes that are benefiting the people you're trying to help, and you can't actually articulate how this integration initiative is making life better, then there might be something missing. Maybe you want to rejig it, maybe you want to let it go. The other thing we found in communities is sometimes there's as many task forces and integration efforts, coordinated access tables, and pilots, etc. There's more of those than there are clients to help. So in Calgary, we had like over 40 tables, but we had 50 clients. So clearly we were, the integration imperative is not necessarily equate to actual client outcomes. So yeah, please have a look at that if you're interested more about this concept and where things can go astray, and some tips about how to ensure that it doesn't, because we give some framework tenets, so things that you want to be thinking about when you take on an integration effort in your community. And of course, it starts with clarifying your objectives and goals, ensuring that you understand all the integration work happening in your community. So you'll be surprised the things that are happening in a community when you actually start mapping them and figuring them out. And when I say mapping, like you do it on an Excel sheet, it's our back of a piece of paper is how we started out. Important part is to then move into getting folks on board in your public systems to do integrated strategic planning work. So your health system sits down with your education and your child intervention, homeless systems, and the leaders start talking about how they align strategy, so that you understand when police, for instance, shifts its strategy, or they're seeing trends emerge in their work, that's going to have downstream impacts in your systems as well. So how are we working together as an ecosystem, and we are understanding each other's pressure points and are able to work towards shared outcomes? Like that's the dream, right? And I'm not saying we've got to figure it out, but that's the goal. And what I also found missing sometimes in communities is that frontline, they kind of do integration as a matter of course, because they have to do that work and integrate at the frontline level to meet client needs. Where we seem to fall apart is at that highest decision maker level. So those, they might be funding CEOs, they might be DMs or ADMs, the heads of the snake, so to speak, in your regions need to also be coordinated and at least meet. In some communities, they don't even know who they've never met face to face. So just very simple things that just can kickstart very different conversations when people are at the right table. And then there's of course the continuous improvement and information sharing that I mentioned already that would need to happen. And all of those tenets are just places to start, or a framework to think about integration in your community. And it doesn't have to just be about homelessness. It's obviously applies across systems. Next slide, please. Yeah, and then of course why this is important, and coming from provinces that are now shifting more and more towards kind of the fiscal imperative and things like accountability and transparency around public taxpayer dollars, etc. This is something that is becoming more and more focused, and because of things like open data, it's easier to trace where funds are going and to start asking questions about those funds as taxpayers, and legitimately so. So why this is important, when we looked at in this same study how funds are being spent, and this is reported by the Canada Revenue Agency, we have contracts that are primarily through provincial and federal governments with nonprofits, and that amounted about $86 billion in 2017, and about 27 billion of that goes into this complex web of about 170 services that deal with our kind of our neck of the woods, vulnerable populations, so mental health, homelessness, addictions, violence, poverty, all these things that are of course interrelated and we want to think about from an integration lens. And so that's coming through primarily through government funding, about 80 to 90% of that, depending on where you are in the country. And so despite that investment, people still say, and you'll hear this on the frontline level, I don't know where to go for help. I don't know who does what. And then our funders and government partners, and sometimes our agencies as well, say, well, we don't understand and we don't have analytics. We don't have a line of sight to these funds either. So it becomes even more imperative from, given our political shifts happening, that we get really intentional about integration and are able to articulate how these funds are spent and how the networks or services work for the common good. And that's just another lens or part of that imperative of why we need to be thinking about these challenges differently. Next slide, please. So when, again, taking that lens, and sorry about my funky writing there on the right, but this is some work that Amanda DeFalco and I are doing in Hamilton, and you're going to hear from her in the May webinar further on some of the great work that they're doing in Hamilton. But we said, let's take a look beyond the homeless serving system, so beyond what her shop, so the City of Hamilton, funds directly, and let's see what this ecosystem, the safety net, looks like in Hamilton, understand who's doing what their focus is, and start to bring some of these key players together in a different way. So this is just a quick overview of the nonprofit sector. This, again, doesn't include the government per se, because we didn't have that data at that time, but about 141 different organizations that do work that's relevant to preventing and ending homelessness. So and this is about out of almost 500 nonprofit charities, and they have about 415 different programs in that ecosystem. Next slide, please. Okay, and then when we mined that further, we said, okay, let's understand what kind of revenues we're dealing with that we can leverage in our work to prevent and end homelessness. So same data source for those nonprofits. We were able to see, okay, interestingly, the city funds about 57 million through its role as service manager and community entity in local systems planning activities, which is good, but as you can see, it's actually not it's not the be-all end-all. So the total ecosystem has about almost $5 billion per year coming in. About $500 million is relevant to our homeless serving system. So the city has about 10% of that it directly controls. Now, the challenge is to start to integrate the full 550 million into a coherent response and service system, because you know, as amazing as the city's team and all those and the Housing First programs that it funds are, they're not going to be able to solve homelessness on their own. And we say this all the time. This is just another angle to tell you that it's also imperative that we connect the dots around the resources, because our clients should benefit from the full ecosystem, and we should be able to actually articulate what that ecosystem looks like and how we refer back and forth, who does what, and rather than building our own little micro system within a system. And that's been my big learning, and coming from managing a homeless serving system kind of one at a time. What happens over time is that you kind of get backlogged in that, so you run out of Housing First spaces, etc. Anyways, so with that, I think what I'm going to do is pass it over to my colleague Dina, who's going to tell you more about what this looks like in practice.
And actually, just before Dina goes ahead, we're going to ask the audience a couple of questions just around systems integration. It's going to pop up on your screen, and you're going to have about 30 seconds to answer, and then we will be sharing the results with everybody. So the first question should be right in here. Do you have integration initiatives happening across sectors in your community? And we'll give you about 30 seconds to respond there. And if you're on the call, we'd really like to hear from everybody, so make sure that you choose an answer there. All right, great. Thank you. So we're going to share the results with everyone so they can see. So 71% said yes, 14% said no, and 14% said don't know. So that's really insightful information. And our second question that we've got for the audience is a two-part question. And we want to know what sectors this integration is happening across. So check all that apply. And again, we'll give you about 30 seconds to respond. So get your answers in.
And I think there's another part to this, like another list, we just couldn't fit it.
Yeah, exactly. There's a part 2 to this question for sure. So if there's a sector that you don't see, it might be on the next question there. All right, great. Thanks everybody for your answers. So we'll share the results from that. So wow, we've got 81% happening in health, 49 in justice, 48 in child intervention, education 32%, and settlement 30. And the second part of the question, we've just got a couple more sectors here. So does anybody know of integration happening within the housing sector, or is there something that we didn't mention here? You can click other. All right, we'll give you another 15 seconds here. All right, great. Thank you so much, everybody, for your responses. So we've got 84% saying housing and 25% saying other. So that's really insightful information for us. So thank you so much, audience, for participating. And with that, I will pass it along to Dina.
Thank you so much. Hello, everyone. And I look forward to presenting a bit of our work about the Abbotsford Homelessness Prevention and Response System. So to this morning's presentation, I'm starting from the place that we are now and to describe where we began. We're currently working on our performance measurement system to support real-time data collection to track and inform how our system is functioning together. We did design our system across sectors, but it is, as Alina had referenced, it is a person-centered system. So we're really looking at rate of change for the individual and how our systems can wrap around support to support rate of change and well-being for the individuals that we are supporting. So we are working closely to align our system with Service Canada's Reaching Home and taking a look at how we can develop community-wide outcomes that align our work across sectors here in our local community. So with that in mind, we are taking a look at Service Canada requirements quite closely to support the areas of improvement that we need to work along and enhance and strengthen what is working well in our community. So the Abbotsford Homelessness Prevention and Response System was developed through collaboration with all levels of government, multi-sectors in our community, so the health, housing, income assistance, public safety, and also taking a look at the community serving sectors for parks, recreation, settlement, etc. in our community. We have a very strong faith-based community here in Abbotsford, so we're very fortunate to have a lot of support from the different faith communities, as well as the Chamber of Commerce, Abbotsford Downtown Business Association, and peers with living and lived experience, as well as local residents. So we recognized through the policy framework at the very beginning that local government does not have the mandate for housing or health or income assistance. So as Alina had mentioned earlier, we couldn't do this work alone. We recognized that. So it really was an opportunity for us to leverage the tools and abilities that we do have at the local level. And that is the ability to convene stakeholders, recognizing what the local conditions are on the ground, bringing everyone together to share and leverage resources, and then also to help inform policy advocacy efforts to senior government. This work was made possible through a Reaching Home Service Canada contribution of $400,000. That was the impetus for us to develop a coordinated intake and referral model here in Abbotsford. We used a dual track system because we heard loud and clear from our stakeholders that they were talked out. And so we needed to ensure that we were showing tangible action along the way. So we employed community-based action research as well as taking a look at all kind of the institutional frameworks at play between the systems. So with that, working side by side, we started the construction of the systems approach. In addition to that, the city appointed a Homelessness Action Advisory Committee, and that's really functioned as our community advisory board that has overseen our work since 2015. In addition to that, we recognized that there were relationships that we needed to repair and a lot of cultural transformation work that needed to happen here in Abbotsford. The collective we, there was work to do to shift from individual agency inputs and outputs to more of a shared person-centered approach. And so one of the key activities that we did was utilizing a collaborative mapping process that helped us to understand what the key capability areas were around responding to homelessness and vulnerability in our community, helping agencies to recognize where they live along this map and align activities across sectors. So with this is an example of the collaborative mapping that we utilized as part of our initial work. And with that, it helped us to launch research design teams. So we've used that for every component of our system. And so we have representation across the systems and sectors on each of the components that we're working on. So with the capability area development, we recognized 4 key areas: prevention support, upstream and diversion, discharge coordination, housing first approach, and that's where our whole intake and referral system lives, as well as support system coordination and sustainability. Our office here at the City of Abbotsford has been the coordination and convening office for the system to date, and we have active working groups through our City's Homeless Action Advisory Committee. So they're very action-oriented. So they're not kind of task force dialogue based. It's more about aligning and assigning action items that each of the stakeholder groups or the organizations that they're representing can support movement along to the shared outcome or the initiative. And so I'll give you a few examples of how that has worked out. So we did utilize the functional zero homelessness definition that I know Alina has done much work on to also further understand and to take a look a lot closer at where the gaps were in our system. So we went from referring to one shelter or one housing agency to taking a look at a shelter system that included our year-round shelters, extreme weather, temporary weather shelters as one system. So taking a look at comprehensively what our community's needs were, how they were being responded to by that system, and what further resources or support was required to ensure that that system was responding to the people's needs. We did that also with housing and health and our community integration, because we employed a community infrastructure approach. And that really helped us to understand that here in Abbotsford and also within Fraser Valley Regional District, we have lacked a critical amount of sustainable funding to address those community infrastructure needs here. So part of our coordinated intake and referral project, we were required to do homeless counts in both 2017 and 2018. So we launched our system in the fall of 2017. So just prior to the system launching, our point in time count surveyed 273 people experiencing homelessness. A year later, when we again went back out for a point in time count, the number did decrease slightly to 233 individuals. Now, that might not seem like a lot, but for the population here in Abbotsford, we're about 150,000 people in total. And with also the lack of housing that we have here in our community and a very low rental vacancy rate, we were at 0.01% rental vacancy rate, and we have no subsidized rental housing for low-income households, or for some people like SROs or single room occupancy. We do not have that type of housing here. So we've had to be very creative about housing solutions. But what we've recognized is the largest percentage of our individuals who are experiencing chronic homelessness are between the ages of 40 and 59. And many of these people are experiencing chronic health conditions alongside struggling with mental health challenges and substance use issues. So that also helped us to inform how we were developing the system. Due to the lack of funding and coordinated response over the years, we do have a significant percentage of our population who has experienced homelessness over a year. And so this is something too that we are taking a very critical look at with respect to our overall response system. There's a significant Indigenous presence as well in our populations who are experiencing homelessness. So it's very integral to the collaborative work that we're doing to recognize the structural and historical barriers and policy challenges that have existed within the institutional cultures of the public systems that are serving many of our marginalized populations here in Abbotsford. So we're leaning in and doing very intentional work in these coming 2 years to better understand what type of culturally appropriate resources and housing and community integration supports that we can incorporate into our systems approach. Also, it's important to note that the work that we're doing is very peer-driven, so we're including focus groups and actual action committees of individuals with living and lived experience to ensure that our systems work is being informed as closely as possible to the individual's needs that we are trying to respond to. So with the obstacles, again, I'd mentioned the housing costs and lack of housing as two of the major issues here in Abbotsford. Also, we recognize that there is a significant need for mental health and substance use services here in Abbotsford, actually across the general population, but it is intensified in our subpopulations of vulnerable people here in our community. So with the systems approach, we did start with a coordinated intake and referral. This was designed through a multi-stakeholder research design team. So our service and housing providers and statutory agency partners alongside the city comprise that research design team. This is a central entry point, which we hadn't had before here in our community. So individuals can apply for housing, health, income assistance, or community integration supports through this coordinated entry point. We have 3 streams of service delivery, and we have also worked through acuity for those streams. So we have low acuity, moderate to high acuity, and high acuity for the systems. And I'll tell you a bit more about how that works out. But with that being said, we recognized that when we were developing the coordinated intake and referral model, we had nothing to refer into. And so that's where really our systems development and design began. And so we had to apply for additional funding to resource our intake function, which is comprised of an intake function coordinator and a housing retention worker. They work alongside the interagency care team. And since the pilot of September 1st, and I think we've got numbers actually up to yesterday, we have received over 529 referrals into our system. So many of the referral sources have been coming from our own city's bylaw department because they're out in the community and also overseeing our parks bylaw that had been instructed through the BC Supreme Court to allow individuals to camp overnight and some in designated parks in our community. In addition to that, with the limited supported housing supply here in our community, it has, again, we're working through how to create more synergies into the housing system. We're opening, with the support of BC Housing in our community, 2 modular housing projects that will be opening their doors in the next few weeks. So we really look forward to seeing how that's going to reduce the number of folks out on the street. But other agencies that are referred into, Abbotsford Regional Hospital, the police department, and multiple agencies. We have had 7 core agencies sign off on a memorandum of understanding as for the systems work, and we're continuing to add agencies and statutory agency partners. So from the intake function, then the coordinator supports doing the vulnerability assessments with individuals, working closely with BC Housing, Fraser Health, our Ministry of Social Development and Poverty Reduction, and our agencies to determine which stream of service that individuals would best be supported by. So we have developed our system with prevention and diversion, accommodation and support, and then emergency response. And so we always recognize that there will be emergency needs in our community, but we are looking at how we can best move the supports farther upstream in our system. So the accommodation and support, or the yellow category that you see with the M, really comprises the bulk of the community that is most vulnerable, who is experiencing homelessness here in Abbotsford, many of whom have struggled with mental health challenges, have active substance use, have trouble accessing mainstream services, and have high impact or utilization of hospitals, may have frequent contact with police, etc. It's not a hard and fast rule, such as the BC assertive community treatment requirements for individuals with high acute mental health issues. It's more about the individuals that we recognize that were falling through the gaps in our communities. So they're very vulnerable. And our interagency care team is a sheriff-funded and overseen team between myself and the executive director for Fraser Health, Mental Health and Substance Use Services. So the interagency care team is comprised of our intake function coordinator, housing retention worker, and then in addition to that, a registered psychiatric nurse, nurse practitioner, and outreach clinicians. They are providing intensive support for 57 individuals currently, as well as our significant conveners and facilitators out in the community. So they help to facilitate a monthly collaborative case planning meeting in the Abbotsford Regional Hospital. They convene an outreach collaboration meeting with all of the outreach service providers in our community. And in addition to that, provide a community of integrated practice sessions with all of our statutory agency partners and other agencies throughout the community on an ongoing basis. What's really special about this team, I call it the heart of our system, because the individual or the participant themselves, all of our process is voluntary, but when they sign up as a participant for the team, the individual themselves can note who their relationship keeper is. It may be an agency, it may be a person. And so the interagency care team does not take over that person from the relationship keeper. Instead, they walk alongside the person and the agency. So it really feels like seamless wraparound support, both for the individual and the agency. And then we're able to take a look at how to best streamline services and reduce gaps. So the interagency care team is housed in what's called the Abbotsford Community Hub Center, and that's an interagency center. We have Fraser Health, Public Health, Mental Health and Substance Use, and Primary Care divisions there. We have access to nurse practitioners. We will have access to addictions specialists, clinical counselors, and psychiatric services. We also have the Ministry and Social Development Integration and Outreach worker there. We have our Housing First Center there that is resourced by the intake function, and our Housing with Abbotsford Rental Connect team, which helps to secure housing for individuals out in the private market with wraparound supports and access to rental subsidies. And also we have an incubator space for some smaller nonprofits, such as Inasmuch Refugee Society and Healthy Aging Abbotsford. And we're soon to welcome a social enterprise staffing solution to provide incremental work opportunities. Our cornerstone agency is Positive Living Fraser Valley. They support individuals with positive diagnosis and also run the drop-in services. And we have two commercial anchor tenants. One is Hub Pharmacy, and the other is Dr. John Farley, who's a Hep C HIV specialist. So we're really showing significant shared outcomes. For example, we have diverted an individual who is a refugee from our Canadian shelter system here locally to the Hub Center, and within a half an hour, he received income assistance, support from the Refugee Society, and the interagency care team supported him to access housing. And I think he even scheduled a health appointment. So those types of things matter when we are the largest municipality in land area in British Columbia. So people have to travel a far distance just within our municipality for services. So this really helps to have everything under one roof.
Thank you. Just to start off, thanks for having me, and thanks for all of our listeners that have signed in and are listening to this webinar. Slide. So Medicine Hat. Next slide too. So Medicine Hat population about 63,000 individuals. Relatively low Indigenous population based on our proximity to reserves and Métis settlements. That will just give you an idea of where we're located for those of you that do not know. When we looked at our last point in time count, we had 68 individuals identifying as homeless in Medicine Hat. So as much as the headlines say that we have ended homelessness, part of me that we actually do have a lot of people still experiencing homelessness in our community. The key element, of course, is systems planning and integration and making sure those individuals can rapidly get out of that state of homelessness. So the Medicine Hat Community Housing Society is a not-for-profit charitable organization that actually has two mutually core supporting business functions. This is really important when we talk about integration, specifically integration. First and foremost, we are what's known as a housing management body. So we actually provide the social and affordable housing in community. And the second part of our core business function is Homeless Initiative. So we are the community-based organization and community entity for Medicine Hat. So my role falls under the Homeless Initiative. So when we look at integration, we, by virtue of design, actually have to integrate on a day-to-day basis. Now, integration does not necessarily mean successive integration. Even as we find as an organization, some of the work we do is actually does not overlay well and does not dovetail well. Some of it does as well. So just keep that in mind as we are going through. Next slide, please. So Medicine Hat system evolution. Important as well when we go through this that really important to note that integration is not a special project that community should undertake. It actually needs to be part of your day-to-day work when you're doing systems planning and systems mapping for your community. When you look at those services, integration needs to be part of the conversation from the get-go or start now. It should not be a special project. So you're not going to see integration in our evolution here because it was from day one. And we looked at how we actually need to serve people well and how we can do things differently. Doesn't mean that we don't have new initiatives and focus on different things as a need arises and as community or those with lived experience identify that need. We just kind of enhance it. We don't launch it or we don't have a special project around it. So our evolution, we have our 5-year plan to end homelessness in 09-10. We implemented our HMIS system quite early on, back in 2009, a coordinated access system in 2010, by name shelter list with our coordinated access system in 2011. So we had a lot of great data. Data has been really important for Medicine Hat as well as performance management. We actually had the pleasure of having Dr. Alina Turner here to do our refocus plan to end homelessness with us in 2014. Really took a strong focus on systems planning and coordination in 2015. I would say 2015 is our year that we really delivered on our commitment to end homelessness and support those most vulnerable in our community. In 2016-17, we saw actually downsizing of our Housing First programs in community, which while other communities are ramping up, we actually had the ability to ramp down on those and start really investing in prevention services and other types of services that would support people to maintain their housing stability. In 2017, we brought online our first 15 units of permanent supportive housing, so a little bit late to the game on that. In 2019, a couple weeks ago, we just got an additional 15 units of permanent supportive housing in community. 2017 and 2018 were actually really critical years in our community, which will tie into the integration with health, and that actually frames some of the discussion here. We had to really rethink our options around the opioid crisis, the number of deaths that we were experiencing, and the number of people that were impacted in community, which was quite significant. And we had to challenge our own systems and our own thinking about how we actually address that. I'm not entirely sure what bringing it home means, but I'm sure I'll figure it out as it goes along. But bringing it home in 2019, 2020 is just our way of fine-tuning some of our systems and some of the work we do around integration and really re-looking at what we have as a system. Really important when we talk about integration that evaluating systems that you, the listeners, are designing. Sometimes they get outdated very quickly and you need to continually go back and refocus those systems and look at how you're integrating. And I'll explain why or demonstrate why when we talk about our work with health. Next slide, please. So Medicine Hat's homeless serving system, just give you a really high overview, then we'll get to the good stuff of the presentation. We have 3 emergency shelters, youth, adult, and family violence. Our family violence shelter actually takes men, which is something quite unique here. Our youth shelter is actually a 6-bed community facility. Through the CBO CE function, we actually fund one of those beds. Some of the programs and services we have, of course, coordinated access system, Housing First program, rapid housing, permanent supportive housing program, a graduate rental assistance initiative specific for those that have graduated through Housing First and rapid rehousing programs, and really are just needing a financial support and are not eligible or are on a wait list for social housing, because that system, the housing system, is quite bogged down in terms of what is available for affordable housing, which is across the country. We all know that. We also fund a youth hub outreach program, a counseling program through our Me Austin Friendship Center. We have a financial administrative program, community-based addictions crisis worker, which we'll talk about a little bit more in the next slide. Drop-in program, which is used to be our winter response. Systems navigators that are actually prevention focused, something unique here. Community capacity building. We also have as well as we have a recovery and stabilization program that I will be talking about, landlord relations, and a lived experience group that will be onboarding and refining actually in this next cycle here in the next month or so. Next slide, please. All right. Here's our health and housing and how we actually integrate. I want to talk about two projects specifically. The first one is a community-based addictions crisis worker program. The second one is recovery and stabilization. These two both involve the same systems that involve health. Justice was actually involved too, so Medicine Hat Police Service was involved in both of them. So we have a little bit of across systems integration, just by virtue of that's how we operate, and they needed to be involved in the discussion. So I'm going to go specifically on health with this one. The reason why I paired these two up together is it's the same people at the table, but the response was exceptionally different. And this is about the evolution in creating those partnerships and understanding in community. So our community-based addictions crisis worker, in 2017, we actually received health money. So not Alberta Health Services, not the service delivery, but actually funding through the Ministry of Health to the community-based organization in the amount of $170,000. Collectively, we brought, it was quite late in the year that we actually got the funding. $170,000, we can do a lot with a little here, which is great. We brought our community partners together, had a dialogue and conversation about what was the unmet need in community. We brought our lived experience as well. So when I say our community partners, please know that includes our lived experience folks as well. We also brought our community advisory board to the table. Both groups independently identified what their level of need was, as actually around addictions crisis workers. Keep in mind, this is at the height of the opioid crisis. Knowing that that was the need, we decided to bring both groups together and talk about who would be delivering the service. Totally had disruptive conversations, and it was around the lack of health responding to the crisis in community. We decided to, as a community, fund our Canadian Mental Health Association to deliver a community-based addictions crisis worker program. Some of the key elements of that program was it needed to go beyond our 9 to 5 hours that Alberta Health Services and that the current system is currently operating in, because as we know, people do not have crisis from 9 to 5. So we wanted to practice outside of the scope. The other thing is we wanted to have a partnership with the police service, actually, because of how many people were getting picked up and put in cells. Alberta Health Services was involved as well, because it's a health response, not a justice response, and not a housing response. So health was also somewhat at the table with us. So when we actually launched this program, health got quite pissed off, quite frankly, because that is their mandate and their scope. As a community, we talked about the ability to leverage some of this and collect really good data and demonstrate the level of need. We knew the need, we did not have the data to back it up. So we were willing to really pilot this and look at the data to help inform future-based programs and services. So it's always fun going into meetings when you know you're going to get perspective, strong perspective from people and leaders in other systems. So that definitely happened. The one thing that we had added benefit is because we have such a great working relationship with the Medicine Hat Police Service is that we actually had the two addictions crisis workers get polygraphed. So they had full access to the police database. And actually, and of course, we had information sharing agreement for those of you that are going, what about this? Of course, we had information and consent from the actual participants that these addictions crisis workers were interfacing with. So eventually, I would say a year later, health finally came around, and we had some very strong conversations because they were seeing the success of the program through the people that they were serving as well. So essentially what we did was we created a parallel system because there was a lack of appropriate response from a different system. So that is not great integration, just to be really clear. That was us forcing ourselves upon a system that we did not think was doing a great job at preservation of life for people with addictions. That program has served they've served 130 individuals to date, so from 17 to 18. When we look at a March 31st end date, they have 49 active people in their program that had not been seen or served by health. And these are individuals that police would pick up on a regular basis. So when we look at cost savings, significant cost savings. So through that and the learnings with Alberta Health Services, and because they came to the table a little bit differently, we looked at recovery and stabilization. I'm going to move on to the second project. So the first project was really the homeless serving system and community partners applying something to a health system. The second project went very differently. This is a fantastic collaborative partnership with Alberta Health Services. This is something, the process was the same in terms that we bring our community partners together, including those with lived experience. And one of the identified gaps was recovery and stabilization for individuals that are waiting for a bed after they have detoxed, and then those that are exiting treatment and actually just need a sober living environment to stabilize before they integrate back into community. The goal of this recovery and stabilization is to provide a safe and supportive, sober transitional environment for individuals, of course, going into recovery. And there's a total of 9 beds available, with the anticipated outcome of having significantly improved health and housing outcomes for those individuals that are either awaiting treatment or transitioning out of treatment. Now, what was different with this project? This one, health was at the table from the very onset. They participated in the community conversations that were held. They actually identified it as a need. So I had the great privilege of a meeting with the head of addictions and mental health here, and we actually just sat down and had a really good conversation about the needs of the people that we were supposed to be serving. The conversation has never been around the needs of the system that are serving the people. So we decided, yes, mandates are important, but people are more important than program mandates. So it was about coming to the table and interfacing where we could, and actually having a collective partnership and a collaborative partnership around that. So how is that different? This project will have a doctor and a psychiatrist that is available on site in this project. They will have direct linkages and workers through our recovery center for either going into treatment or coming out of treatment. And from the housing perspective and homeless sector, we are providing the housing in one facility, ensuring that people have rent paid, as part of any of our programming would do, and that we would actually provide the workers from a housing perspective and a support perspective. So where this integrates well and where we have some really good success is the understanding of what this program will do. There is absolutely no exchange of money here, no funding from Alberta Health Services to housing, and no funding from housing to Alberta Health Services. So when we think about integration, it does not need to be the exchange of money. It needs to be in the best interest of the people that we serve. A couple key elements with the recovery and stabilization project is we agreed, so housing as well as Alberta Health Services agreed that there would be no length of time for people on this project. However, understanding that people do need to actually move beyond this and get housed in community or go to treatment. We just don't know how we want to define the length of stay right now. So we're going to monitor it collectively. And in terms of the sober living environment, this is something new for Medicine Hat. We've never had a kind of a restricted environment because we've always been harm reduction based, but we're looking at this as a choice for people as well. We say sober, however, if people relapse, we know that relapse is a part of recovery, that they will not be evicted from this facility or program, so as long as they don't use on-site. So if someone is out and chooses to use and comes back on-site and discloses, they will not be evicted on the spot. We will have to work with Alberta Health Services to put parameters around that and look at what that means for the program and the success of the program as well. We are looking to launch this program in June and July of this year. We got to put an RFP out for a service provider, and part of that is really refining with Alberta Health Services what the roles and responsibilities are, so we have clarity. Something that we build into our agreements and that we message with our community partners, whether it's a system or a regular community partner and program provider, is that it will change, and for them to expect a lot of change as we learn about the programs as that we're delivering. The best laid proposal does not mean the best practice. So we make sure we include and embed the ability for those programs to shift and change to meet the needs of the people that we are supposed to be serving. Next slide, please. learnings and lessons, or lessons and learning. Integration and interfacing of systems and services. Know when you need to really get in and know the nitty-gritty of how systems operate and where you do not. A lot of time is spent studying different systems and knowing the ins and outs. Systems and processes change so quickly that what you might have known a month ago has changed. So just be really cognizant of the level of information or the programs and services that are built into systems, that those change quite frequently. So know the level of detail that you need to know. Again, that integration is not a special project. It's just something that should be embedded in your day-to-day work and operations of what you do. Disruptive conversations. This is something we talk a lot about from a Medicine Hat perspective. Have them and actually learn to appreciate them. If you're not having disruptive conversations, you're not pushing the status quo hard enough. And that's our perspective. You can have disrespectful and respectful conversations, and that happens a lot. But if you're not willing to go there and actually have the conversation about what's not working, not for the systems, what's not working for the people that you're supposed to be serving, that's problematic. Don't think that's making a huge impact if you're not willing to just go there and have the difficult conversation. Reset and refocus. This was a really important learning for us with Alberta Health Services, based on the community-based addictions crisis worker and the recovery stabilization. Same people in the room, very, very different approach, very different facial expressions at the table. A true collaborative effort with Alberta Health Services. Their ability to reset and refocus and our ability to reset and refocus and just come to the table new again is a part of how Medicine Hat operates and a huge part of our success. Egos. Make sure you leave your ego at the door. We thought we knew what we were going into when we were looking at recovery and stabilization. This project has actually been on our books for quite a while, and we couldn't actually proceed without health at the table with us to actually help guide and inform some of that practices, because their system had changed so much here. And across Alberta, actually, in terms of what was funded or what was not funded. So really be aware of those egos. You might not know what you don't know, which is true of everyone. And impact. Can't say enough about impact here. First, go for the impact of the people that you're supposed to be serving. I know I sound like a broken record when I say that, but when we're doing this work, we forget the impact on the people we're supposed to be serving and remind systems of that. Yes, everyone has organizational mandates. Try to blur the line a little bit and really go towards the people that we are supposed to be serving and have the difficult conversations. And in closing, just want to share that if systems are not coming to your table, we actually experience this quite a bit in Medicine Hat. I like when we talk about the last participant polling that we just did, how effective are the systems integration. I think for the extremely well, mildly, or not at all, I would probably click all of those. And depends on what month it is in our community and what's going on for those other community partners, and depends what system we're working with. So we still experience a lot of barriers and a lot of challenges with the systems that we integrate with, but there's always a willingness to come to the table and have the discussion and learn from that. Something I do want to share, this is something that Health actually brought up with us, was around our community-based addictions crisis workers. Our community lived experience group and our partners had mentioned that there was a lack of Indigenous focus. So that is something that our CAB actually decided to fund this year, was actually to add an Indigenous crisis addiction worker and actually couch that not within the program, but within our Indigenous group here, the Meowson Friendship Center. So that program is up and going as well. It's a housing funded program, but it will integrate with health, much like our other programs and services do here. Thanks.
Great, thank you so much. So now we're going to turn the tables to the audience. We have some questions that have already come through, and at this point we encourage anybody who hasn't already asked a question but who has one to type their question into the question box, and we're going to go through the questions and have the presenters answer them as they can. So the very first question came up during Alina's presentation, and it asked, why is PDD not mentioned? And this question from Angela.
Yeah, it should be absolutely mentioned in, I think you're probably talking about the Edmonton system. And so it would be probably just an oversight. And PDD is part of social services department, or at least was when Edmonton was doing their plan. Who knows where things are going to end up now. But yes, it absolutely should be. And PDD, for folks that don't know, persons with developmental disabilities.
Great, thanks. Great. Thanks for your question, Angela. So now we move on to a question, and this is for Dina, and it comes from Victor. So Dina, you made a reference to senior government. Victor's wondering if this is provincial government or a health authority.
Oh, thanks for the question, Victor. When I refer to senior government, I mean both federal and provincial government. So our statutory agency partners for the province has been BC Housing, Fraser Health Authority, because they're our health authority in our region, and Ministry of Social Development, Poverty Reduction, and the Solicitor General's Office. With respect to federal government, we've had a very strong working relationship with Service Canada, Reaching Home, as well as the Rural and Remote Service Canada with Pignata in Prince George.
Great, thank you. And thank you for the question. We have another question for you, Dina, and we'll just ask you now. Ralph wants to know if you could talk a little bit more about modular housing.
Oh, yes, absolutely. So that is a BC Housing initiated program, and it's rapid response to homelessness. And so we are very grateful to have received 2 modular housing projects here in Abbotsford. That comes with integrated health supports from Fraser Health. But what we have found by taking a look at modular housing as part of our housing system here in Abbotsford, we've been able to initiate assessment and placement through an allocation table process where our interagency care team and our MOU partners are working alongside BC Housing and Fraser Health to ensure that individuals are being referred into the modulars with the best support and wellness plans possible. And so it's been a really good collaborative effort. We really see that it's going to make a significant difference for 81 individuals, but still there is a huge need for supportive housing in our community. So the modular housing construction, though, is really interesting to see as it goes up rapidly as well, and I think that that's something that BC Housing has initiated across our province.
Great, thank you for that answer. Our next question comes from Michelle, and Michelle is wondering how you capture your mental health data. And I don't know if this is specifically for Dina, it might be for the full panel. But Michelle said in Michigan, it's difficult to capture secondary to privacy laws, and also because many people are undiagnosed or not connected to mental health support. Are any of the panelists able to weigh in on that at all?
Amy, do you want to take that one and how you guys handle that in Medicine Hat?
Yeah, you betcha. Really great question, Michelle. So the mental health data is collected. It's self-reported, first and foremost. So individuals' perception of how their mental health is, that's always front and center with us. In terms of getting information from health and other systems, because it can be from justice as well, actually, for a number of incidences, is we actually have information sharing agreements. If it has to do with people's housing and housing stability, typically information is shared. Now, that is not to say that it is shared freely. Informed consent from participants is a magical thing, as long as they know what information is being shared and the purpose of why it's being shared. That information, our police and our first project, our community-based addictions crisis workers, is a great example where those workers actually have access to a lot of information, including health information as well in terms of people's mental health and well-being as it relates to housing and their addiction. So we're really careful about the access to the information and what we use it for.
I can also speak to Abbotsford just briefly. We also have information sharing agreement that was part of our memorandum of understanding with our core service agencies for our systems work and our statutory agency partners. And because we've developed key performance indicators and shared outcomes for each component of our system as well, we're taking a look at integrating data outcomes, such as using the World Health Organization's quality of life indicators. And we've integrated Fraser Health's kind of internal indicator system through the social determinants of health, and then that ties into our overall collaborative outcome mapping outcomes. So with that, we are starting to develop an integrated system that tracks wellness and housing retention and community integration outcomes for the individuals that are being referred into the system. It's not a perfect system because we don't have access to a digital platform at this time, but we're working towards that.
Wonderful, thank you. Our next question comes from Judith, and the question is about the cost per client of services and how you scale that to reduce costs and increase client load. It wasn't addressed to any panelists specifically, so anyone wants to jump in.
Yeah. So, I mean, I can speak generally and then I'll pass it to Jamie and Dina, but generally the way you gain efficiency is through scaling. So there's not necessarily that there's a magic number, and it depends on the program type too. So for instance, if you have a 10-bed permanent supportive housing building, that's going to be more costly to operate than a 30-bed permanent supportive housing building. So there's some scale challenges, but of course you need to maintain quality. So you need to be thinking about neighborhood fit and matching the acuity of the program to the level of need of participants and all of those things. In terms of what else could be done that is not as obvious, I mean, there's certain things that Housing First programs could leverage from other sources as well. So for instance, and again, Jamie can speak to this, there's ways that you can engage your public health system to deliver health services in your Housing First program. So instead of hiring your own nurses or doctors to deliver those services within your ACT model or your intensive case management program, you might be able to create a partnership so that you're leveraging resources that are already out there. So then you're filling in the gaps and you're focusing on the things that the homeless serving system does immediately without having to build it out yourself. The other one is to get really, really smart about understanding what's in your community and leveraging that. So oftentimes once clients become stabilized, they talk about things like self-actualization or connection to community recreation, things like meaningful daily activities. And that's a huge deal to staying housed long-term and transitioning to community. But oftentimes what we also do is we tend to build those within our programs, which again takes resources. However, if you understand the broader ecosystem and understand the various existing opportunities in your community around well-being, so learning opportunities, education and training, those are all things that are mainstream and available and are already out there. So building those partnerships could also reduce your need to do those other pieces of work. But Jamie might have more tips as well.
I think, Alina, you nailed the response in terms of the scaling to cost per client and leveraging existing services and resources. We're really careful here in Medicine Hat. This is going to be counter to what I said about the addictions crisis worker, where it was a very intentional, very well thought out, strategic way of funding a parallel system to get a response from a system. But the system actually really likes what we're doing with that. So we're actually going to keep it, and that's an agreed understanding. In terms of actual cost, we go cost per program here. Just to give those listeners an idea, our community-based addictions crisis workers, the one program runs at a cost of $195,000. And we already talked about how many people they serve. And the Recovery and Stabilization Project has a $250,000 budget attached to it. Now, that seems very low because it is. Keep in mind, no health dollars are attached to that because they are showing up to the table with their doctor and psychiatrist and all their workers as well. So the cost that we have associated with that program does not include, not even the gift in kind, it is not that. It's the partnership amount that Alberta Health Services not will absorb, but will just provide those services to this population, our mutual clients. So those mainstream services should always come to the table because they exist for every other population. Just because someone's homeless or experiencing housing instability doesn't mean we need to create a separate program for a mainstream service that any one of us can get at any given time. It's ridiculous to think that the sector should fund those types of services when it's available to other people. Now, that being said, that's not the reality all the time in some of our jurisdictions, especially rural and remote, where you might actually not have that specialty or that service available into your community where you actually do need to fund that. So I'm not saying don't do that. Look to your community first and what's available. Look to your system, integrate that way first, and then add if you need to.
Great, thank you so much. So we have a question for Dana about the implementation of HIFIS and how it's impacted the integration work being done.
So Abbotsford, being that we're in British Columbia, BC Housing has worked closely with Service Canada to receive the agreement for HIFIS. So we are awaiting BC Housing providing us opportunity as a community here in our province to access HIFIS. But in the meantime, we have done as much work as possible to align our local system to BC Housing's coordinated access system that they've generated. It has been an on-the-ground challenge for us to be able to develop a data system. So we are taking a look at other options. We also have our city web application that has the ability to create a web-based platform that we can house our systems work with. And so that's why we're very much looking forward to the help seeker work with Alina and Travis that's upcoming as well, because I think it will also help to kind of align some of that data coming in where we can populate that web-based platform. And then when HIFIS becomes available, we hope to be able to integrate into that system. So then we're strengthening and working alongside BC Housing's objectives as well.
Great, okay. So I'm just noticing the time and we have lots of great questions and won't be able to get to them all. So I'm gonna just take two questions, I think, and ones that kind of speak to our topic more generally. If you have specific questions for any of the panelists, they'll give you a little bit of information about how to connect with them afterwards. But for right now, we have a question from Najina, and sorry if I mispronounced that, but Najina's question is, what is the best way to get the leaders or top individuals with money to pay attention to local projects, especially when you don't have local data?
Oh,
Ooh, I like the question.
You want to talk about that? Yeah, go for it.
I'm going to friendly persistence and coffee does wonders. Keep showing up. The conversation is going to change over time. Let people warm up to you a little bit. Use data from elsewhere. So whether that's at a maybe provincial level or information from another community, if you don't have the local data. I'm not sure in the context, Najina, pardon me, if it's like you don't have like current data or if it's an outside rural remote community. So just in the absence of that, find your nearest like community or city or whatever that looks like and use their information. There's enough information out there that we know Housing First works. We know there's a cost savings for people. We know it's the right thing to do. So whether it's a financial draw for people or a moral draw or a personal draw, find a little bit about who you're trying to tap into, find what really drives them and tailor it to that. I know in our community with our mayor, he's a financial advisor. So our approach with him was data. Yes, we had the data, but even in the absence of data, we could do the cost savings approach with him because, and he wasn't going to go based on the morality of things. That came eventually when the understanding was there, but find out what drives people and what area they're in, and if they're into philanthropy or if youth is their thing or adult stuff or addictions, find it in that way. Study people.
Great advice. And I want to get to one last question, and this comes from Raidan. And again, I apologize if I mispronounce that. But this question is about whether or not there are online platforms or places for communities to connect with other communities for support through the systems planning journey.
Well, it's
Alina.
in the works. It's in the works. So yeah, absolutely. We're working on a network of systems planning communities. And yeah, if you're interested, I would say keep watch on the Homeless Hub channels, because that's where you're going to see that come through. There's a couple of things that are going to happen. First things first, there's always going to be a monthly webinar with different communities, so you can of course stay tuned for future discussions. The May one, for instance, is going to be about coordinated access using this holistic lens and systems prevention integration lens. So that's going to be announced shortly. And there's folks like Amanda from Hamilton is going to present on their work, and we're working on a few other presenters as well, just to highlight the good and the learnings from communities as well across the country. And then the other piece is that we're also launching kind of a more informal, I wouldn't say it's Q&A, and I forget what we're calling it, but that's in the works for every 2 weeks to have kind of a call-in hotline almost online, and it's going to be recorded as a podcast where communities can just engage with one another and online, and it's a facilitated online discussion, and it gets podcasted as well through the Homeless Hub and disseminated out. But you can submit questions there that are a little bit more sensitive. And you can do that anonymously. So things like, how do I deal with big egos in systems planning, or how often is it okay to be really wanting to quit my job because it's really hard work. So there's that opportunity for us to have a bit of a safety valve and have these more open discussions, and we'll have a guest in those podcasts as well that folks can interact with, and you can interact with one another. And that's going to be, it's in the works right now. I believe it's with communications and design to figure out the schedule for that. And then lastly, there's going to be a workspace online through the Homeless Hub under the Systems Planning Collective stream, where you can share resources with one another, and there's you can just not blog post, but online forum essentially as well. So if you're into that, then stay tuned, because we have quite a bit of stuff in the works. And if you have ideas, please send them on to us as well. And I think we'll share an email maybe of where to go to get more information, and where to submit some ideas and suggestions. So Dina thinks, she says it's a great idea for the podcast and convo style format. Yeah, so we want to make sure it's accessible to everyone, and folks have a chance to open source and crowdsource some of the solutions, because everybody has amazing ideas all across Canada and beyond. So those of you that are joining from elsewhere. And everything gets recorded as well. So you can share this, feel free to share out everything that we send out to you and to your networks. So hopefully that helps answer that.
Great, thank you for that in-depth answer, Alina. And that brings us to the end of our webinar. I want to thank Alina, Dina, and Jamie for joining us today and sharing some great insights. Thank you to the audience for joining us as well. A couple of you had questions about whether or not this would be recorded. It will be, and it will be sent around to everybody who was with us today. We'll also make the slides available for anybody who missed any information. And we'll also make sure that the contact information of each of the panelists is available, so that if you do have questions or want to reach out to them after the webinar, that will be easy for you to do. So thanks again, everyone. Have a wonderful day.